What do you have to say about this 5F technique, ma'am? How is it different from the regular glued IOL we do?
This gets rid of the disadvantages of both and retains the advantages of both. Glued IOL, for example, you have to make scleral flaps, and this does not need the surgeon to make scleral flaps. So you don't have to be worried about have you made too thick flaps, have you made too large flaps, have you made too thin flaps, have the flaps torn out, any of those issues. And then also it doesn't need fibrin glue.
It's a pleasure having Dr. Soosan with us today. Welcome, ma'am, for our podcast.
Thank you, Preethi. Thanks a lot.
And she's known for her innovations, and let's hear her talk about her latest innovation, which is the 5F technique. What do you have to say about this 5F technique, ma'am? How is it different from the regular glued IOL we do?
Okay, thanks for that question, Preethi. 5F, basically, let me start with what it stands for. It stands for flangeless, flapless, fibrin glueless, fully covered and fully tugged. Intrascleral haptic fixation. So that's what it stands for. And when I first started it out, I was doing it with a pocket technique. But then I, changed it further and made it as a pocketless technique. So now I call it as pocketless 5F ISHF. So it's a long name, but because I've sort of made it into an acronym, now it's, it can fit in your mouth. Pocketless 5F IOL. So what this basically changes the way intrascleral haptic fixation is done is that as compared to the two commonly performed techniques, which are glued IOL and Yamane, this gets rid of the disadvantages of both and retains the advantages of both. So if you look at it, glued IOL, for example, you have to make scleral flaps. And this does not need the surgeon to make scleral flaps. So you don't have to be worried about have you made too thick flaps, have you made too large flaps, have you made too thin flaps, have the flaps torn out, or any of those issues. And then also it doesn't need fibrin glue. So that's another big problem. So example, if you're doing just one case a day, you have to open a fibrin glue for that one patient. It does add on to the cost of surgery, and in many places fibrin glue may not be available freely either. So now you are no longer dependent on the availability of fibrin glue. Those are when you compare them with the disadvantages of glued IOL. Now, comparing them to the advantages of glued IOL, it still has the same intrascleral haptic fixation, which gives glued IOL its great stability. In fact, it has an additional roughly around 2 millimeters extra of haptic fixation than glued IOL also. So it's a very stable intraocular lens fixation, and also the ease of doing the centration, the tilt, all these things become just as it is in glued IOL. So you have a very well fixed intraocular lens. Now, compared to the Yamane IOL, the Yamane has the problem of flanging, and flanging is something that I personally never used to like. The issues with flanging are it's an irreversible modification of the haptic. That haptic is irreversibly changed, and then you cannot do anything to undo it. And also your flange may not be exactly the size that you want it to be. Sometimes you take the low temp cautery, it becomes too much or it's too less. Sometimes if it's too much or the IOL may get decentered to one side, and then you try to do it on the other side and you keep going back and forth like this. Or if it's too large, it doesn't get tucked down well enough, and then it causes the flagpole syndrome, where it can, in the post-operative period, pop out and come out of the sclera or the conjunctiva and show up there, erode the overlying conjunctiva. These are all issues with the flanging. And the other thing is, if the flange is too small, by chance it can even slip back in. So it takes away this entire need of flanging the haptic. It takes away the need to have two needles inside the eye at the same time. That's another thing with Yamane. You have to leave the first needle in while you're manipulating the second needle. And again, that's a needle that's left not in your control, not held, but freely there, can sometimes cause peripheral retinal damage and things like that, or at least that's in the back of your mind. Where is the internal side of the needle at that moment? So this is also taken away. You've already externalized the first haptic, and then only you go to the second haptic. So there's always only a single needle within the vitreous cavity. So these are advantages as compared to Yamane IOL, and I think this is where the 5F IOL scores over these two techniques. That it makes your life much easier, keeps the surgery easy, takes away the disadvantages of both, and also decreases the cost.
That's a wonderful explanation, ma'am. But I would just like to ask one question for beginners. Someone who has not done glued IOLs, you think they should learn to do the flap technique and then shift to the 5F, or you think it's easy enough for someone to transition immediately to a 5F technique?
Okay, that's a very good question. I think for those who have already been doing glued IOLs or Yamane IOLs, this becomes a very easy technique to transition to. It really leaves nothing to be actually learned extra. For those who have not learned, I would say learning either of them would be equally, would be almost on equal footing. So even for the glued IOL, you do have the learning curve for creating the flaps and all those things, which also is there for the 5F IOL in terms of internalizing the haptic. So the learning curve would be the same, I think. But if you already have experience with doing ISHFs in any form, then this becomes really much easier.